All right, today we have the honor and pleasure to hearing from Dr. Johannes Jungwirth. Dr. Johannes Jungwirth is a key member of the Psychiatric University Hospital in Zurich, specializing in psychiatry and psychotherapy. His academic journey began at the Medical University of Vienna, where he pursued his medical degree, delving into neuroimaging and ketamine research. This work laid the groundwork for his profound interest in mental health. Dr. Jungwirth's professional focus as a senior physician is the treatment of patients with difficult-to-treat depression. In the second opinion consultation, he offers intervention treatments such as transmagnetic stimulation, ECT, laughing gas, esketamine, MDMA, and psilocybin. A noteworthy achievement in Dr. Jungwirth's career is his pivotal role in establishing the first compassionate use program for psychedelics at the Psychiatric University Hospital in Zurich. This initiative marks a significant milestone, positioning the clinic as the inaugural provider worldwide to offer psychedelic therapy outside the context of research studies. This program reflects Dr. Jungwirth's dedication to making innovative treatments accessible to patients and a deep-seated desire to bridge the gap between cutting-edge research and real-world patient needs. His research has been instrumental in shedding light on how psilocybin therapy can enhance emotional empathy and social cognition in individuals with depression, contributing to the broader understanding of new treatment avenues. So without further ado, let's introduce Dr. Johannes Jungwirth.
Well, thank you very much. Can you hear me? Is it fine? Yeah. Quite a pleasant and friendly introduction. I hope I can live up to those expectations. We'll see. Yeah. As you can see, I'm going to talk about the role of psychotherapy in psychedelic research and treatment. And the subtitle of my talk is Diving into a Fierce Debate. I'm going to guide you through what I'm going to mean with this fierce debate. Another title of my talk, I proposed it to you actually, would be What do geese have to do with the psychedelic treatment of depression? And I'm going to talk about that goose a little bit later. First of all, I'm going to show you what we're going to talk about tonight. We're going to talk about the debate, the current debate I'm referring to. We're going to talk about the current paradigms and some historical paradigms also. We're going to have two thought experiments. We'll talk about the goose. We'll talk about the pros. That means like the arguments in favor of the necessity of psychotherapy and psychedelic treatment. We're going to talk about the cons, the arguments against the necessity of psychotherapy and psychedelic treatment. We'll have a little outlook, and then I will provide you with a take-home message, and then we'll have plenty of time for questions. So, the debate. Like roughly speaking, the debate is about this question. Is psychotherapy necessary for the efficacy of psychedelic treatments? That's it. That's the debate. And because I want to learn something tonight also, I want to ask you if you have heard about that debate, if you're familiar with that debate or not at all. If you're familiar with it, just raise your hands, please. Okay, well, a lot of you know it. And what do you think? Do you think it's psychotherapy is necessary for the efficacy of psychedelic treatment? If yes, just raise your hands. Okay? And who thinks it's not necessary for the efficacy of psychedelic treatment? Okay, much less than in favor of it. Cool. I think the arguments against it, they will be more exciting for you probably than the arguments for it. First of all, we have to talk about two terms used in psychedelic research and treatment. The first term is psychological support. Psychological support means basically the assistance for somebody to cope with intense situations or stress or crisis and so on. And the goal is to comfort, to make comfortable, to provide coping strategies, and to make somebody feel safe. On the other hand, psychotherapy, well, it's difficult to define it with one sentence, but because there are many schools, as you know. But basically, it's the treatment of emotional, behavioral, or mental disorders. And the goal is, depending on the school, but the main goal is to understand, to address, and ultimately to change something. Yeah. That's for terminology for now. And the debate started with this letter written by Guy Goodwin. It's a professor from England, working with psychedelics actually quite a while. He did the biggest study to date with psilocybin and depression, with around 250 patients. He's also the chief medical officer of Compass Pathways, a for-profit pharma company who's trying to make psilocybin approved by regulatory authorities. And he wrote this article in the American Journal of Psychiatry like 2.5 years ago, and he questioned the necessity of psychotherapy in the treatment with psychedelics. And well, I read it several times actually, the commentary, of course. It's not that easy to distill the main argument he has, but he says basically that what we are doing in psychedelic trials is not psychotherapy, it's psychological support. And the main driver of the efficacy of the antidepressant effect is not psychotherapy and not the psychological support, it's just the drug. And psychological support is just provided for reasons of safety. Well, and that letter or that commentary provoked a major outburst in the psychedelic community. 7 responses in different journals came up. Fierce responses beyond reductionism, group from Mannheim, a cart without a horse, the whole is not the sum of the parts, must not be retired, misinterpretations and omissions, a critical response to Goodwin and so on. Is poorly assisted psilocybin treatment an increased risk? Psychotherapy safe, evidence-based, and necessary. So you can see what I mean by fierce debate. Interestingly, really, those comments, they came out like a month later, and that after peer-reviewed process. So they were really quick and wrote for their ideas. And I think it's really an interesting debate. Of course, that's why I'm standing here today. That's why I'm interested in it. But let's take a step back. What we're talking about here? We're talking about psychedelics in psychiatry, and as you all know, we have a range of psychedelics we are researching on, and it began with LSD 25 in the 1950s or 40s, let's say, and LSD is more or less the mother of research on it, and also the mother of subcultural and pop cultural development of psychedelic culture. And ayahuasca, you see here, that's a compound from the Amazonian, DMT, and then MAO inhibitor. Iboga, it's a plant from Western Africa with the ingredient like the molecule ibogaine, studied in PTSD research and addiction treatment. Psilocybin, we're going to talk about psilocybin tonight, of course. Peyote, a cactus from Northern America, Mexico, with mescaline as a molecule. MDMA, it's not a classic psychedelic, or not a serotonergic psychedelic, of course, but it's also important in our research and treatment. And 5-MeO-DMT, well, it's a very potent psychedelic who appears in many plants and animals. Yeah, but we will talk about psilocybin. And why we will talk about psilocybin? Because there's the most evidence on psilocybin, and also because we in Psychiatric University Hospital, we treat patients with psilocybin, as Paul already said. since 2 years now in the limited medical use program. Yeah, here you see all the important, well, the only RCTs done with psilocybin and depression. And as you can see, I don't know, it's like 7 or 8 now. On the left corner, you see the study from Goodwin. On the right side, do you see my mouse? Yeah. On the right side, you see our study from Zurich. And you know, those lines, they mean the depression rate. All of those are depression rates. And this upper line is the placebo group, and this lower line is the psilocybin group. And as you can see, all of those studies showed significant and really strong effects for the treatment of depression. I have to mention on this occasion also that all of those studies have limitations, and the major limitation in all psychedelic studies is the functional unblinding. You've heard about it. It's very difficult to blind the drug. You know, everybody knows who got what, and that means, yeah, of course, that means that people who got in placebo, they are disappointed and they don't get better, and people who get the verum, the drug psilocybin, they know it, and the expectancy bias causes then a stronger effect than it is probably in real life. Okay. And how were they done? That's the interesting question now. How were those studies done? And well, basically, it's very simple. All paradigms in psychedelic treatments follow this rule, like follow this paradigm or scheme in 3 phases. The first phase is the preparation phase, where the people come for at least one, but mostly 2 or 3 sessions, where they get to know the therapist, where they speak about expectations, where they speak about how to deal with the substance administration. Second phase, they talk about difficult topics. In all the manuals and all the protocols, it's advised to talk about difficult topics because they probably will arise during substance administration, and there needs to be a trust to let those topics come up. And almost all the studies with psilocybin also include something called intention making, you know, goal setting. They set goals. What do you want to change? What do you want to have different afterwards, after the thing? And that's what we call intention. Second phase is the administration, or we call it also the substance day, where people come to clinics and get the drug in the morning, and then are surveilled or guided, depends what terms you use, by a therapist through 6 to 8 hours. And there's not like the idea is that there's not so much talking happening. The idea is that people look into themselves. We call it introspection, and the only real intervention the psychiatrist or the therapist is doing is choosing the music, basically. But also, of course, there's talks, and then we will provide care and comfort. We call it psychological support when there's intense emotional processing going on. Third phase is integration phase. Afterwards, like minimum. Yeah, mostly in most studies it's like 2 days afterwards or a week afterwards, and all the studies have at least 3 integration sessions. And what does integration mean? Integration means, well, it's a long topic also. I don't want to talk about it so deeply today, but people talk about what they experienced. They talk about what they felt. They talk about the problem, like the insights, if they happened. They talk about this very strange experience that people made on the administration day, and they try to make sense out of it. And that means that they look for meaning or implications for the daily life or their personal healing journey. Yeah, and then just for information, another two terms I want to mention here. That's what we call basically psychedelic therapy, and this is based on research and theories by Stan Grove and Humphrey Osemond and a lot of other people, and it's typically done with high doses, and it's typically done just for 1 or 2 sessions. And in all the studies, they have maximum 2 sessions. Sometimes, most of them have only 1. And then you have like terms like peak experience, emotional breakthrough. That's what you want to achieve. Acceptance and commitment, and rebus. That's relaxed beliefs under psychedelics, a theory from England, from the research group in England. And then on the other hand, you have the tradition of the psycholytic therapy. And that's not so known now then, it's not so used also, and there's basically no research on that, like only old research done by Hans-Karl Leuner. It's more also the European approach and deeply rooted in the psychoanalytic tradition. You have multiple sessions with low doses in order to achieve free association and softening of defense mechanisms in short. Okay, that's some import for now, and now we have a thought experiment. And for that thought experience, I brought somebody here, and this guy is called Emo, and Emo is a young man. You can see he's smiling, he's fun, he's doing good. But sadly, we have to lock him up into a cellar, and after a few weeks being in the dark, he gets depressed, as you do when you are locked up into a cellar. And and you can see it. I mean, he's sad. And we are therapists or psychiatrists, and we think about what can we do to help him. And we decide to give him antidepressants, like a SSRI or so. And the thought experiment now is, do we think that he's getting better when we feed him with antidepressants? Yeah? No, he's still in a cellar. Well, I guess the answer would be no, I think, yeah. And that's actually something Alboni and colleagues, they tried out in a study in 2011. They did it with mice. They had depressive mice, and they split them up in 2 groups. One group got placebo, and one group got fluoxetine, like a SSRI, classic, a typical antidepressant. And on the top row, you see the mice getting placebo or SSRI in an enriched environment, and down there you see in a stressful environment. And what you can see is that the white columns, they are the ones with the placebo, and the black columns, they're one with the SSRI. And you can see that those mice with the SSRI, they got better. The depression got better in the enriched environment when they got SSRIs, better than in comparison to the placebo group. And then the interesting thing is, in the stressful environment, you can see that those who got the SSRI got even worse than the ones who got the placebo. So they had an increase of anhedonia during treatment with fluoxetine in stressful condition in comparison to placebo. So what does it tell us? The author said the effect of the SSRI on depression in mice is not determined by the drug per se, but is induced by the drug and driven by the environment. So if the environment is stressful and you get a SSRI, and SSRI also provide neuroplasticity, you get worse than the placebo group. Yeah?
The diagram said, how do we know that the mice are depressed in the enriched environment?
No, all of them, they were depressed in the first place already.
All of them were in dark, closed environment.
Sorry?
All of them were in the dark and closed environment.
No, it's not a dark and closed. It was that was just the thought experiment I made up. all of them were depressed, and they were either put in an enriched environment or in a stressful environment. Yeah. I have to look up the model, but typically, yeah, I have to look it up. But there's certain ways you can do mice experiments with depressed mice and make sure they're depressed in the first place. Sad. Another interesting high published study is this one. I really think it's very interesting. They took a bunch of SSRI studies and they meta-analyzed it, and they provided those lines. And you can see here in the middle is the placebo line. That's the patients, depressive patients, human who got placebo. And those are the ones who got SSRI and did respond to the treatment. Of course, they got better than placebo because SSRIs work typically. And then they split up the people who got SSRIs into the responders and the non-responders. And here you can see that the non-responders, but the ones who got SSRI nonetheless, they got worse than the ones in the placebo group. So again, maybe evidence for something the authors call an undirected susceptibility to change model. So not the drug is the thing, but the context is the thing. Yeah. And that's we have to come back to psychedelics now. That's one landmark study from Lai et al. 2018. Just showing that psychedelics, in this case LSD, is enhancing neuroplasticity. You know, here's a mouse neuron again in salt solution, and here's a mouse neuron in LSD solution, and you can see neurons and dendrites and so on spreading. Yeah. And neuroplasticity, I think you heard all of it. There's some talks about neuroplasticity. You can look them up also on YouTube from pros. Yeah, it's the ability to change and learn. Okay. And now we'll talk about the goose. Finally, this guy, he was a biologist from Austria, and he won the Nobel Prize in the 1970s for his research with geese. And he found out that geese, after hatching, like after getting out of the egg, after being born, they have something we call now a critical period of learning. He called it also, open state or availability to be imprinted, Prägung in German. And this period has a certain amount of time, and whatever they see after hatching, moving object, they will remember for the rest of their life, and they will refer to that person, or like you can also have a basketball as their parents, and that's something he got the Nobel Prize for. And why am I telling you this? I'm telling you this because colleagues from Johns Hopkins, they did also research with something we call critical period of learning, and they found out that psychedelics, they can reopen that critical period. So in mice again, and here you see how long those substances open up the critical period of learning, of social reward learning in that paradigm. Get them in 48 hours until ibogaine in 4 weeks. So again, what I want to tell you with this is the things you do after having a psychedelic trip, they matter. And then interestingly, this lab also found or like correlated the time of the reopening of this period matches with the acute subjective effects in humans. It's funny, no? It's interesting. Of course, it's a preliminary research, let's say, but it's really interesting, no? Yeah. That was the goose, but we are not geese and we're not mice. We are men and women, and And here we go with our next thought experiment. We remember Emo. You remember him? Still sad, still depressed, poor guy. But out of the cellar, and he comes to our clinic, university clinic in Zurich, and we will provide him with all the stuff you like, and all the really strong neuroplastogenic things, and we reopen his critical period of learning and enhance his neuroplasticity until he's fine again. You can see he's smiling, he's happy, and we say, Emo, it's fine, you can go home now, and have a good one. And he comes home and he sees this. What now, you know? Shit. Yeah. As you can see, I'm setting the stage for the arguments in favor of the necessity of psychotherapy. Yeah. Yeah, let's go through the arguments in favor of the necessity of psychotherapy. Yeah, we heard about the undirected susceptibility to change model. We heard about that in the context of SSRIs, but I think it's especially relevant in psychedelics because they increase suggestibility and they increase neuroplasticity even more than SSRIs and therefore seem to be more context-driven. Something called dark neuroplasticity, a term that also, I think I explained it to you, says that neuroplasticity by itself is not beneficial, but it depends what you do with it. You can benefit from it, but you can also get dark, you know, and reinforce maladaptive patterns, for example. And also reopening up of critical periods of learning via psychedelics. If you combine that neurobiological grounds with psychological research, which says that psilocybin increases psychological flexibility, and this correlates with the improvements in depression. And if you look at research saying that ketamine plus CBT extends the antidepressant effects, and those psychological experiences like emotional breakthrough and so on during psilocybin correlate with the antidepressant effects. All that put together shows us that there's some kind of window of opportunity that you should use for the benefit of the patient. And in the worst case, it could reinforce those maladaptive patterns and make them even stronger. Another argument for the necessity of psychotherapy is the expectancy. People come to our clinic and they have really high hopes, you know, and of course they have high hopes because they're depressive since years or decades already, and they see Netflix documentaries or media coverage where people show healing processes. They're amazing, you know, and a molecule that changed your life and saved you, really. And then we have to manage those expectations. It's not an easy task, actually. And psychotherapy is something that can ground in that expectancy and give back the responsibility to the patient. You know, they come with high expectations and they want to give them up, you know, to something like a drug and think about, this can reset my brain finally, and I'm done, you know, with all my symptoms and so on. But it's never the case like that. And providing or setting psychotherapy can embed that and can empower the patient and tell and show them that actually they are doing the work, not the molecule and not the therapist. They are doing the work. I saw an interview like 2 days ago with Rick Doblin, and he says empowerment is the best antidote against cultism and guruism in the scene. We are helping patients to learn how to heal themselves, not the drug, not the therapist, nor the healer. Not the drug, not the therapist is the healer, but the patients themselves. And I think it's really important that we remember that molecules, they don't change lives. They cannot change lives. People change lives. Yeah. Another argument in favor is the current evidence. If you look at the studies, we have to say that all of those studies have applied psychotherapeutic models, and there's no way of isolating the effects provided by the therapist, of isolating it from the effects of the psilocybin. It's quite difficult. And even in this study by Goodwin, the critic, and there were at least 7 hours of therapy sessions all over. And he himself wrote in the method sections that the goal of the integration sessions was to support participants in deriving their own insights and solutions from the experience of psilocybin. And for me, that doesn't really sound like psychological support. It sounds like psychotherapy. And all the study therapists also, they had excessive psychotherapeutic training. You know, you can look it up in this study, Tai et al. They show how all the study therapists in this Compass study by Goodwin were trained, and they provide tons of psychotherapeutic models. Another argument in favor is the transdiagnostic efficacy. There's preliminary so far for all those kinds of disorders, depression, treatment-resistant depression, in bipolar 2, alcohol use disorder, nicotine dependence, pain disorders, OCD, anorexia, PTSD, anxiety disorders. So you have a bunch of disorders who apparently respond to psilocybin and other psychedelics, but they all have different neurobiological mechanisms. They don't respond, all of them, to SSRIs. But what they do have in common is they all respond to psychotherapy. So this adds up also to the theory that the psychedelics are maybe just a catalyst for the psychotherapeutic process. And another argument in favor is the ethical safety argument. Research has shown that around 10% of healthy users have significant emotional impairment after drug intake, around 10%, little less. And that rate could even be higher in a psychiatric population. And therefore, I think psychotherapy is essential to handle those eventual worsenings of symptoms and this kind of psychological destabilization or problem activation. I think also out of a safety perspective, that's important. And also maybe out of an efficacy perspective, maybe we can make use of that problem activation. And then the therapeutic relationship, which is stronger in a psychotherapeutic relationship than in a psychological support relationship, is a crucial factor in for providing a good trip, actually, and a stronger positive effects, which then correlate with better outcome. So we want to set the stage for meaningful and positive experiences, and even if it's just a neurobiology or just a psychological experience, I think we need a certain degree of psychotherapeutic embedding to provide a proper set and setting. Okay, that's the arguments in favor of psychotherapy. And now attention rises for the arguments against the necessity of psychotherapy. First argument is based on epidemiological studies. There's large data sets from the US saying that the lifetime use of classic psychedelic is associated with an significantly reduced odds of past-month psychological distress and suicidality, whereas other illegal drug use was largely associated with an increased likelihood of those outcomes, and that without psychotherapy. So maybe it's just a drug. There's also other reviews saying that, like large-scale population-based studies, saying that positive effects on mental health and pro-social effects in non-medical use of psychedelics. There's one meta-analysis which compares the psychotherapeutic models of 10 RCTs, and they couldn't show a difference between the models. I'm not so sure if that's really an argument against it, and also they, for example, they falsely defined our study manual as non-manualized, which it wasn't. So that's just one study done by now. Let's come to a bit stronger argument against the necessity of psychotherapy, and it's basically a visual one. Yeah. If you see all those studies I showed you before already, if you see all of them, you see that the antidepressant effect took place right after the dosage day, the administration day, and prior to any psychotherapy happening. You can see here, that's our study. The blue bar here, that's when they got the psilocybin, and they got immediately better. And with the psychotherapy or the integration sessions, as you want to call them, it didn't get any better. Okay, and all of those other studies showed the same, actually. Maybe this one a bit, but it's not significant. So why the integration sessions? And of course, there's no comparative studies. We don't have studies comparing psychotherapy on just psychological support. There's only one comparative study with healthy participants, and that shows primarily the dosage as a predictor. It's a really interesting study if you're interested in this topic. They had 75 healthy participants, and they went into all of them went into a meditation training, a spiritual practice training, and they had 3 groups. The first group got low-dose psilocybin and standard support in spiritual practice, and then there was a high-dose group with standard support, and then a high-dose group with high support. Yeah. And after 6 months, there was only a minor difference between the high-dose groups, either with standard or high support. And the high support group significantly improved in positive social effects, positive behavior changes, and increased spirituality. So it means high support is good, beneficial, but it also showed an increase in negative attitudes and self. That's strange, no? Because and I can't explain it, and the authors also didn't discuss it so much. And for me, it's also not really sure if that's an argument against it, but it's a really interesting study on the topic. Yeah, the other side of the argument that they did provide psychotherapy in the studies is, did they really provide psychotherapy in the studies? Because all of the studies, there were maximum 12 sessions in total, typically more like 5 or 7 sessions. And that's what we would call short-term psychotherapy. But also all the manuals, they had a non-directive psychotherapy model. And if we think about non-directive psychotherapy models like psychoanalysis, all of them, they need very lot of sessions, and that's not short-term interventions. Short-term interventions typically are very, directive psychotherapy. So can we say that the studies provided psychotherapy in a narrow sense? Kind of contradictive, but still open to debate, I would say. Yeah, and then just a thing I want to mention: subjective effect and psychological effect during the drug administration is a different topic than the psychotherapy. Yeah, and then I come to the main argument against the necessity of psychotherapy, and that's an ethical one. It's about access and inclusivity, because psychotherapy is a resource-intensive approach. There's long waiting times and high costs. And an unquestioned linkage with psychotherapy would risk something like exclusivity. For example, you need to speak the language, like refugees, for example. They would have to learn language before people who cannot afford the therapy or endure the waiting times. So that's an important topic we have to be really careful about answering. Yeah, and here we go with the outlook. So we have valid arguments in both sides, let's say. There's a large consensus in the in experienced scientists in favor of the necessity of psychotherapy. I think we still know very little. There's many questions and new questions. And what to do about it? We need new paradigms, we need new ideas. And yeah, I just mentioned that universitarian scientists should think outside of approval strategies, because pharma companies, they earn only money on the drug. They don't earn money on the therapy. That's why they want to hold the therapy part low. Yeah. And what to do about it? 4-arm RCT, that would be an approach, isolating the effects of the drug and the psychotherapy. You would need one arm getting psychedelic and psychotherapy. You would need one arm getting psychedelic and psychological support. Then you would need an arm with placebo and psychotherapy and one with placebo and psychological support. Then you could isolate the effects of each compound. Of course, then it would be interesting to get a 9-arm study getting psychedelic and a 5-HT2A receptor antagonism to block out the subjective effects and get psychotherapy, and block out the subjective effects getting psychological support, and so on. But there's not enough money, of course, for that. But it would be interesting. Yeah, the take-home message I would provide is that there's no evidence-based answer to the question yet. There's many new and exciting questions to be answered. I think it's really interesting. And probably there's really an individual answer. There's people who don't need psychotherapy, but I'm sure there's some people who don't need it, and there's many who need it. Let's be open to that. And my personal opinion is that psilocybin is rarely the end of a medical history, and it is usually the beginning of hard work on it. And now I'm done, and thanks a lot for your attention.
Thank you so much, Johannes. As usual, we have some time for questions and potential answers. Just raise your hand and we'll come to you with a microphone. We're recording it for the podcast and we're going to upload it online so the questions can be heard as well.
Thank you. Hi. One of the slides you showed, the slides on which you showed the results from the studies, where you had I think it was occurrence of depression over a specific amount of days.
You mean this one?
Yeah, that one. Mm-hmm. I can't see the amount of days, but is there anything that's tracked the results more long-term? Because you said that the effects, obviously major effects are observed right after administration, but is there any very long-term tracking? Because with psychotherapy, as you said, depending on the methods, you have results after months or years.
Yeah.
So my question would be, it's a bit imprecise. Is there anything that's compared the long-term and short-term effects? I don't know how, because you see the curve is going up in your study, for example.
Well, there's, I think, 2 studies from New York who did a long-term outcome analysis, one in 6 and one in 12 months, I think, and they all showed still a significant effect, but I'm not sure about the psychotherapy provided there. And I think they don't have the data. I don't know if they checked if the patients had psychotherapy afterwards with their own therapists, but I'm not sure if I answered your question.
Yeah, sort of. It was just, I was kind of, it's answered.
Yeah. Okay.
So is the reason that we don't have comparative studies, as you mentioned a couple of times, is only because of ethical and legal concerns. So is it the reason that that it doesn't pass the ethics committee?
No, I don't think that's the reason. I think it would pass the ethics committee, committee, whatever. You know what I mean? It would be
Second
safe,
slide.
because there's those arms with the psychological support, they would be safe also because
Yeah.
because it's basically for safety.
Mhm.
So I think the reason that didn't happen now is money and time, and the research is still quite young, like the contemporary research on it. We will see that kind of research soon, but it takes a lot of money, to have a 4-arm trial.
Thank you.
Thank you very much for the talk. You mentioned the important thing that so in all the studies only the short-term psychotherapy was studied, but still even in the existing studies, were there any differences found depending on what approach of psychotherapy was used? Because I can wonder that the approaches like psychoanalysis, which like means that you delve a lot into your past experience, can actually be harmful because, as you said, psychedelics like increase the openness. So it can actually increase the openness to your negative experiences in the past.
Yeah, that's a good question. Also, those guys try to answer that and try to distill the different psychotherapeutic models they did in the studies. Basically they split it up in non-manualized and manualized and non-manualized, non-directive and supportive psychotherapy, whatever the study authors mentioned in the method section, and they didn't see any difference in the outcome. But none of those studies mentioned that they do psychoanalysis in their studies. That doesn't really make sense. But typically, all of them are quite, like the majority of them are quite non-directive, and they, for example, there's the MAPS, the MDMA and PTSD studies. They have something they call activate the inner healer, and they do something really like subtle with the patients. Then they don't go really directly into exposition therapy and so on. So I would say all of the studies they somehow provided similar psychotherapy techniques, which were more on an open mind base to provide space. Yeah. So no, they did analyze that, but there's no difference between these therapies. Yeah.
Thanks for the talk. I have a bit of a two-part question. The first question would be, earlier you showed a study where mice got SSRIs.
Yeah.
And where the critical period was reopening. And I was wondering to what the critical period refers to. Because I assume there's critical periods for different processes, mechanisms.
Yeah. Yeah, you got me on this question a bit, because they had a quite difficult paradigm in the study. It was basically, can you hear me still? Yeah, yeah. It was basically done with mice in a social reward learning setting, where like mice had either like friends around them or not. And this was also marked with a certain kind of floor, and how they did remember the floor. Please read the study now. Do it AL 2023. It's a quite difficult paradigm, but they could show that the social reward learning period would reopen up after taking the psychedelic, similar to the neuroplasticity after being born, you know. Yeah.
Right, thanks.
Half-baked
And then
answer.
the second part of the question was something along the lines of like a more conceptual question. If the reopening of the critical period can be understood or can be taken synonymously as neuroplasticity.
Yeah, it could be. Yeah, it goes into the same direction. That's true. Yeah.
Thanks also for the talk, and maybe also something to add to the question before regarding the psychotherapeutic interventions administered. A lot of the studies also are very lacking in their descriptions.
Yeah.
And that's a big problem in analyzing these differences, because a lot of them don't really provide much information what they do.
Yeah.
It's also that the reporting is very often non-descriptive, which is changing, I feel like, but it's a big problem to compare these studies. And
yeah, that's true. Yeah, if we had like open source protocols or manuals for the studies, would be really interesting to compare it like really in depth.
I have a question about, you mentioned that a lot of the effects are maybe due to the placebo effect, not the placebo effect, but the expectations of the patients that they will get better, like this image you showed from the Netflix documentary, that a molecule change your life. And I would imagine that in the past, when the first antidepressants were discovered or introduced, there was maybe also these high expectations that they would work.
Yeah.
So do you think that the first studies looking at the effects of antidepressants had higher effects due to this? And do you expect that in the future maybe studies with other substances will have decreased effects because people will start to question their efficacy?
Yeah. It's quite proven actually that SSRIs, when they started, 80s, 70s, 80s, they had much higher effect sizes than they have now. And that's also due to, but that's a typical bias. Something new is always better than something old. But they don't have this real significant problem of unblinding most of the time. People, it's not so easy. Like, it's not that easy to guess correctly which group you got in. And to the second question, yes, I think psychedelics will like the efficacy of psychedelics will be corrected negatively. They will not provide the same efficacy in clinical real-world settings than they do in studies.
So I'm new and uninformed in this field, but I was just wondering, how do the minds and depressions of mice compare to the human?
Yeah, good question. That's what I said also. We're not mice. That's a topic we call translational research. How can we translate mice studies into human research? It's difficult, that's true. Yeah. It's really difficult, and also, for example, the neuroplasticity theory is based on those mouse studies here, as you saw. But we have basically only EEG studies providing evidence that psychedelics enhance neuroplasticity in humans. And there came out a recent meta-analysis by Abigail Calder, who's talking here also soon, that, for example, the BDNF rates, that's a hormone that induces neuroplasticity, doesn't really rise after psychedelics. But because, yeah, what I want to say is that the research is still very young, and the neuroplasticity research on psychedelics is even younger. And I think we will see that your question is valid because mouse, they have totally different, probably totally different responses to psychedelics. So it's difficult, yeah, true.
Okay, with that, we're going to conclude our talk tonight. Give again a large thank you for Johannes for taking the time to coming to us and sharing all of this.
Thank you.
Okay, now we have a free apéro for you. Just feel free to help yourself. Thank you all for coming. Again, I can highly encourage you to come next Wednesday when we have a patient speaking. That's going to be absolutely fantastic. If you want to learn more about the neuroscience, we also have a neuroscience talk. Yeah, you'll see. All right.